I have no disclosures. So the patient was a 17-year-old male who presented to COI for evaluation of binocular diplopia and headaches that were present for about 2 months. He had no change in visual acuity. His past medical history was significant for APC mutation. He had a history of multiple polyps throughout the entire colon and had undergone a total abdominal colectomy 10 months prior to presentation to our service. His past ocular history was unremarkable. Family history. The biopsy confirmed germinoma. It was placental alkaline phosphatase positive and showed neoplastic cells with prominent nuclei and a prominent lymphohistiocytic infiltrate. As you can see here in the center of the image, this cells is the prominent nuclei, the clear cytoplasm, and more in the periphery, the prominent lymphohistiocytic infiltrate. And here's the PLAP staining. It's a placental alkaline phosphatase, so it goes along with the germinoma. As managed for neurosurgery, he was starting to see anything abnormal on imaging studies on those undetermined cases. We're not, given the history in our patient, there was things that were unusual. We're not thinking that was a congenital case of a fourth nerve palsy. For congenital fourth nerve palsy, old photos may show a long-standing head tilt. As I mentioned, the mother was pretty sure that the head tilt was new. She mentioned to us, oh, this is new, it was present probably for about 2 months. And patients with a congenital fourth nerve palsy usually have a large vertical fusion amplitude, maybe greater than 6 to 8 from that particular study, was to image when there was progression of the palsy or no improvement within 2 months. Or, as in our case here, atypical aspects of the history might be key indicators for early imaging. The third one is Turcotte syndrome, the association of multiple polyps and the primary CNS neoplasm. There is a classification, type 1 and type 2. Type 1 would be a colorectal adenoma without polyposis, and the patients have colorectal polyposis and a primary CNS neoplasm. The APC gene was cloned in 1991, is located in chromosome 5q21. There are hundreds of adenomas and polyps early in life. Our patient had undergone, as I mentioned, total abdominal colectomy 10 months prior to presentation. And the pathology, we found greater than 300 polyps throughout the entire colon. There was some mild dysplasia, but no evidence of malignancy. So it's important doing prophylactic colectomy in those patients because there is almost a 100% progression to colorectal carcinoma by age 40. As I mentioned, the patient also had 2 pigmented ocular fundus lesions in the periphery. These lesions, in association with the APC mutation, are usually, in this case here, it was located in the periphery as well. So at this point, I will open up for discussion, take any questions.
Very nice. Comments or questions?
In that retrospective series that you were, in that retrospective series that you're mentioning, I mean, was there a neurological, what section did neurological issues
in that particular,
for the sense of malignancy? Because I didn't see any section in that.
In that particular study, they didn't find any cases that had a secondary neurologic cause. There was another study by another group that showed 5 case reports with a secondary cause. One was a schwannoma, the other one was secondary to bleeding, as I mentioned. And there was one, they presumed to be a pseudotumor causing, there are a few case reports of pseudotumor presumed causing fourth nerve palsy as well.
The big series was from an ophthalmology group, correct?
Correct.
Yeah. If you had a series from a neurosurgery group, there'd be more tumors.
Mm-hmm.
Yeah.
What they are. So anytime you see several of these in any patient's eye and they do not look like animal tracks, then the flags really should go up as being indicative of a polyposis. There've only been maybe 1 or 2 patients in the literature that were discovered to have polyposis as a result of having been found to have the eye lesions first. More often than not, the history of the disease is established in the family. It's a dominant trait. The reason why only 80% of patients with mutations have them is a very interesting phenotype-genotype correlation, where the location of the mutation in the gene determines whether there's an ocular phenotype or not. I can't remember what exons it is bound by, but within exons, let's say 3 and 15 of the gene, you will have fundus lesions.
It's
but
1 to 8 you don't have fundus lesions, and 9 to 15 you have
right.
fundus lesions.
So it's a very interesting observation, and we don't know why that is. And in this particular patient, you see these lesions in the fundus. The patient comes in with what looks like an acquired fourth nerve palsy. That is definitely a reason. In addition to all what you mentioned as to why it is an acquired and you need to image it, but that's also another reason to think along the lines of a malignancy. It's very uncommon for us to see a tumor as a cause of a fourth nerve palsy, at least in our practices. I don't recall having a single case since I came to the clinic.
This is my first case
Yeah.
in 12 years. And I think the main point is we're always taught that 80% of the time the answer is in the history. And a lot of times we're in a busy clinic, we may go in and just trust the history that the technician took. And this is a situation where I went in and the mother just kept really insisting that he's changed. And it didn't pass the smell test for me. And so it's just that intuition that something's just changed about this kid. I typically don't image fourth nerve palsies. In children, they're either congenital, this didn't quite fit, or they're trauma in a 17-year-old. So I was really pushing, he bumped his head, right? Something happened, because I didn't expect this at all, but it just wasn't fitting, and so I just, almost by providence, imaged him.